Well, I'd like to, first of all, just thank everybody for having me here and giving me the opportunity to talk on what's a very important topic, especially here with the Southwestern Health Resources Network, looking at an accountable care organization and trying to curtail costs. As we'll talk about here momentarily, this is one of the big areas for potentially making a difference. So just in terms of disclosures, I act as a consultant for K2M, but not really relevant for my talk here today. So just to give you an overview of the talk today, we'll go through a little bit of the epidemiology of back pain, go through some of the different causes, as well as some of the associated conditions that make patients at increased risk for low back pain, some of the red flag symptoms that really you should be looking out for and quizzing the patient on to try and extract those patients that are high risk for having a significant underlying problem, and then understanding what's the natural history and what happens to these patients ultimately. So just with the epidemiology, this is a huge problem. Back pain is akin to the common cold of medicine. Upwards of 80% of all patients will be affected by back pain at some point during their life. And so basically 4 out of 5 individuals in this room, if you haven't had it, you will. Also, the other thing that we know is that the incidence of back pain is increasing over time in both our young patients as well as our older patients. If you look at the studies that have been performed over about a decade and a half, looking at younger and older patients, the incidence is increasing, much more so in the older population than in the young, but definitely increasing in both. Part of the reason for that is the change in our overall society in that we've become a lot more sedentary. If you look at patients that come in complaining of back pain, over half of those patients will have a fairly sedentary job and spend the majority of their day sitting behind a desk. So again, this is an issue that's only going to increase. Just like the previous talk where we talked about the impact and the cost of care, this is one where it's enormous. Looking at the direct cost for back care in the U.S., it's on the order of $50 billion a year in direct costs. And then if you look at the indirect costs associated with either unnecessary testing, unnecessary surgery, the medical legal costs associated with it, it's another $100 billion on top of that. So we have a $150 billion issue here. One of the things that, and part of the reason that we're having this symposium is that you look at, despite the, relatively speaking, modest increase in the incidence of back pain, there's been an enormous increase in the incidence of imaging. So if you look here in this study performed on Medicare beneficiaries, over, again, about a decade, there's over 300% increase in the incidence of MRI scans for patients with back pain. So again, clearly we have a problem. When you look at that as it then dominoes into costs, again, that's $100 billion a year. $100 billion a year in imaging costs, and it's estimated that somewhere between 2 to 16% of that is considered waste. Again, unnecessary imaging, patients that didn't need imaging, or imaging that was performed premature. For those that are in this room, this is a very relevant issue in that most of the patients that present with back pain will see you first. About 40% of patients will first present to their primary care physician. Another 40% will end up seeing someone like a chiropractor, and it's only a very small percentage of them that will see someone like myself as in their initial presentation. And so when understanding back pain, it's important to understand what's the underlying cause. And so when you look at the different anatomic structures that can be problematic, you have things such as the intervertebral disc, the bone pathologic compression fractures or benign osteoporotic compression fractures. You have really non-related spine-related issues such as the sacroiliac joint, which is a common source of pain, and then the common sources like radiculopathy as well as the musculature. When you domino that into the pathologic manifestations, then we get into things like disc herniations, spinal deformity such as scoliosis and adult onset deformity, which is increasing in incidence. Things that are very worrisome like spinal infections or neoplastic processes can also present with back pain. And so one of the things that's key is trying to tease out and extract the benign conditions from those that are more sinister. Again, patients that are more susceptible to back pain are those that have metabolic bone disease. Patients that have inflammatory arthropathies such as rheumatoid arthritis or psoriatic arthritis have very high incidence of pain. Conditions such as syringomyelia can also present with it, and then patients with arachnoiditis, either iatrogenic from multiple surgeries or patients that have had the old myelograms from years ago that would often incite this sort of condition. There's also a number of masqueraders, so things outside of the spinal column that can present as spinal pain, but again, the underlying source is not in the spine. Those include things like trochanteric bursitis, which is extremely common in this patient population. Those are the patients that are going to have pain in the hip and groin region when they're going up and down stairs, painful to lay on that hip. Osteoarthritis of the hip commonly, again, can present as radicular pain. One of the hallmarks there is that it tends to really radiate into the groin area, and that can sometimes kind of tease out that it may be related to the hip and not the back. There's also medical conditions such as peripheral artery disease that can overlap significantly with neurogenic claudication. Again, the difference being the postural nature of the neurogenic claudication symptoms versus the peripheral artery disease symptoms. And then things like multiple sclerosis, which is always on the differential for doggone near everything that we have in medicine. In looking at the type of pain, that it's important to distill back pain into its underlying a little bit more granular detail. Basically, what we do is we want to see if this is a radicular pain. So this is the classic sciatic pain that radiates down the leg into the buttock. Again, you can throw neurogenic claudication into this symptom or into this category as well, where patients have pain in the buttock area, heaviness in the legs. This is often due to an underlying disc herniation or some sort of neural impingement. But the important thing to know is that despite there actually is a pathologic diagnosis underlying this, the majority of these patients will get better without needing any sort of specific intervention. Then you have one of the more difficult types of pain to treat, which is what's referred to as axial pain. And this is back pain that really has no postural component to it. It's kind of mid-back pain that's always present, whether the patient is upright, sitting, standing, walking, it doesn't make a difference. And this is often nonspecific in terms of the subsequent imaging findings. And this is also the patient population where they tend to be very desperate for help, but they're also the ones that tend to be harmed the most by something as seemingly benign as getting an MRI scan, because there's always a finding. And that often will lead to surgery, which will lead to not so good outcomes. The last type of pain is what we refer to as mechanical pain. This typically is related to some sort of underlying structural abnormality, including things like compression fractures, spondylolisthesis, and things of that nature. The key here is that the pain is very postural. So when the patient has load on their spine, so when they're standing or sitting upright, they have significant pain, and that pain is nearly completely relieved when they lie down flat or they unload their spine. These patients, again, typically have some underlying structural abnormality, and these are patients that you're going to be a little bit more worried about. So as it pertains to the diagnosis, it begins, as always, with the history and physical. Only then, when there are appropriate items that are picked up, do you go on to diagnostic imaging, and may there be a need to refer to someone like myself or our spine team. And again, I can't emphasize enough that the history and physical is the absolute most important thing here. We want to know things like the timing or the quality of the pain. Is it always present? Does it depend on what they're doing? What's the location of the pain? Is the location consistent, or does it change? Are there associated symptoms or medical conditions? So is the patient diabetic? Do they have a history of IV drug abuse or immunosuppression? And then, of course, if there are any objective neurologic findings, such as pathologic reflexes like Hoffman's or Babinski sign. And the goal here is really to rule out the surgical conditions. These are going to be patients that have a progressive neurologic deficit, and sometimes it's not always clear when interviewing the patient that they have a neurologic deficit, but if you quiz them enough, particularly on things that require fine motor control in their upper extremities, you can sometimes tease out that they may have some early signs of neurologic dysfunction that may be an indication for cervical spondylitic myelopathy, which is one of those surgical conditions. Again, the history can also clue you into potential spinal instability based on the nature of their pain and the provoking factors. And then things like the cauda equina syndrome, where we're looking for saddle anesthesia, leg weakness, as well as radicular pain. One of the things with cauda equina syndrome to remember is that it's not always the classic triad. So a patient can actually walk into your clinic and have cauda equina syndrome. They have the other symptoms, particularly the bowel and bladder dysfunction, so you have to keep your radar up for that if the patient's complaining of urinary or bowel incontinence. The red flags that we look for, these are really helping to tease out those patients that have, again, these surgical conditions or a more ominous underlying diagnosis, such as bowel bladder dysfunction, weakness, and again, the weakness can be very, very subtle. Often in females, I'll ask them about things like putting on earrings or jewelry or buttoning buttons on their blouse. For gentlemen, oftentimes they've gone to having their spouse button their buttons on their shirt for them, or they can't put on cufflinks and things like that anymore. And again, that can sometimes clue you in. Then you have things that are more concerning regarding constitutional symptoms like night sweats, unexplained weight loss. Again, that can be a hallmark for an underlying malignancy. This table here, taken from the recent ACR recommendations regarding screening for diagnostic imaging. And again, what we're looking to do is categorize and extract patients that have diagnoses such as cancer, infection, fractures, and things that threaten their neurologic function. Those are patients that you're going to want to image earlier. Other patients are very safe in delaying imaging into an appropriate time of conservative care has passed before ordering an MRI scan or a CT. You can also take solace in the fact that the majority of patients, when looking at those patients that presented to their primary care physician for back pain, the majority of patients, over 90%, were nonspecific. Only a very small percentage of patients are going to be things like a spondylolisthesis, and a very, very small fraction of patients are going to be tumors and things of that nature. Often, again, if with detailed enough history, you can extract those patients early on and appropriately manage only those with imaging early. This table here, this is more for reference, but the only thing I would really like for folks to take away from this is the bottom category, is the psychological distress aspect of back pain. This is one of those areas, back pain in particular, where you have to treat the whole patient, including the between the ears aspect of the patient, because that can significantly play a role in their interpretation and their experience of pain. It's also an area where engagement with the patient and educating them about back pain and what's causing it, and also the benign course of it, and the deleterious effects of getting that MRI scan just because to rule out a bulging disc or whatnot. Oops. Again, the majority of patients are going to do very well. Over 90% of them will get better within a 6-week period of conservative care. On the flip side of that, however, we are all human, and so often when patients feel better, they go back to doing that same thing that led to the back pain in the first place, so there's a very high incidence of recurrence, upwards of 80% of patients. Fortunately, though, only a small percentage will go on to having more prolonged chronic pain. So again, reassuring the patient that it is a benign course, and if they just stick with it long enough and kind of believe in you and partner with you in their care, they can get better without needing anything extravagant or expensive. Looking at those patients that, again, the different treatment options, prescription medications are very effective in over 60% of patients, chiropractic treatments as well, and then physical therapy can be very, very effective. Looking at this entire group, again, over 90% will get better with one or more of these treatments or nothing at all, what we refer to as benign neglect. And even those patients, again, that have a pathologic diagnosis like a herniated disc, upwards of 85% of those patients will get better without needing any sort of surgical intervention. And again, that's the last thing I'd leave you with. Even though I'm a surgeon, it's very, very important to remember that only a very, very small percentage of patients actually need surgery for their back pain. Only 5% on average will ultimately need surgery. There are a lot of good, very effective options that will allow them to get back to their desired quality of life without having a scar to show for it. So in conclusion, again, natural history of back pain, very common but benign. Nonspecific back pain is the most common cause. You want to screen for the red flags. Those are going to extract those patients with worrisome diagnosis. Engage with the patient, reassure them, and also avoid bed rest. It's a bad thing. Thank you.